Welcome to this lecture on arthrology, the study of joints. In this video, we'll cover joint classification, the anatomy and types of synovial joints, and one of the most important topics of physiotherapy, that is joint mechanics. What is arthrology? It is the study of joints or articulations. It includes the structure of joints, how joints are classified, the movements they allow, and the factors that contribute to joint stability. For physiotherapists, the understanding of arthrology is extremely important because joint structure directly influences movement and function. When we understand how a joint is built, we can better understand how it is supposed to move, what can restrict its movement, and how different physiotherapy techniques may influence that movement. Joints can be classified structurally into three main categories: fibrous joints, cartilaginous joints, and synovial joints. The main difference between these categories is the type of tissue connecting the bones and the amount of movement that is possible. Let's look at each category. Fibrous joints are the joints in which the bones are connected by fibrous connective tissue. They do not contain a true joint cavity and generally allow very little movement. There are three commonly described types of fibrous joint: sutures, syndesmosis, and gomphosis. Sutures are found between the bones of the skull. A syndesmosis is a fibrous connection in which the bones are connected by a ligament or an interosseous membrane. A good example is tibiofibular joint. A gomphosis is the type of fibrous joint that connects a tooth to its socket. So overall, fibrous joints are designed primarily for stability rather than large ranges of movement. The second category is cartilaginous joints. In these joints, the bones are connected by cartilage. Cartilaginous joints can be divided into primary and secondary type. A primary cartilaginous joint or a synchondrosis is connected by hyaline cartilage. One example is an epiphyseal plate during skeletal growth. A secondary cartilaginous joint or symphysis contains fibrocartilage. Examples include the pubic symphysis and the joints between vertebral bodies, where the intervertebral discs are located. Cartilaginous joints generally allow more movement than fibrous joints, but less movements than most synovial joints. The third and the most functionally important category is the synovial joint. Synovial joints are generally free, movable joints and are characterized by the presence of joint cavity. They contain specialized structures that allow movement while helping to reduce friction and maintain stability. Most of the major joints of limbs include the shoulder, elbow, wrist, hip, and knee are synovial joints. Because these joints are so important in physiotherapy, let's examine their anatomy in more detail. Why does joint classification matter to a physiotherapist? Because structure influences function. The tissues that connect the bones determine the amount and type of movement which is possible. They also influence the stability and the way the joint responds to loading. Therefore, understanding joint classification gives us foundation for understanding normal movement, movement restrictions, injury, and clinical treatment. A typical synovial joint contains several important structures. These include the joint capsule, synovial membrane, articular cartilage, ligaments, and joint cavity. Depending on the specific joint, additional structures such as bursae, menisci, and labra may also be present. Let's look at these structures individually. The joint capsule surrounds the synovial joint. It consists of two major layers. The outer layer is the fibrous capsule. The inner layer is the synovial membrane. The fibrous capsule provides mechanical support and helps maintain the relationship between articulating bones. The capsule can also contribute significantly to joint stability. If the capsule becomes shortened or stiff, it can restrict joint movement. The synovial membrane lines the inner surface of the fibrous capsule. It does not cover the articular cartilage. One of the major functions is to produce synovial fluid. Synovial fluid helps to lubricate the joint and contributes to the natural nutritional environment of the articular cartilage. This allows the joint surfaces to move with relatively low friction. Articular cartilage covers the articulating surfaces of most synovial joints. It provides a smooth surface for movement and helps reduce friction between the bones. It also helps distribute loads across the joint and contribute to shock absorption. Healthy articular cartilage is therefore extremely important for efficient joint movement. Damage or degeneration of articular cartilage can alter joint mechanics and may contribute to pain, stiffness, and functional limitations. Ligaments connect bone to bone. They are important passive stabilizers of joint. Ligaments help guide movement and limit excessive or unwanted movement. As a joint approaches the end of the available range, certain ligaments may become increasingly tensioned. This tension contributes to joint stability and can also influence the resistance felt during passive movement. A bursa is a small fluid filled sac that helps reduce friction between moving tissues. Bursae may be located between bone and tendon, between muscle and bone, or between other structures that move relative to one another. When a bursa becomes irritated or inflamed, movement may become painful and restricted. A meniscus is a fibrocartilaginous structure found in certain joints. The most familiar example is knee. The medial and lateral menisci help distribute loads across the knee joint. They also contribute to shock absorption, joint congruency, and stability. So, the menisci are not simply passive cushions, they also play an important role in joint mechanics. A labrum is a fibrocartilaginous rim around the edge of certain joint sockets. Two important examples are the glenoid labrum of the shoulder and the acetabular labrum of the hip. The labrum helps deepen the socket and contributes to joint stability and load distribution. This is particularly important in shoulder, where mobility is very high and stability depends on several interacting structures. Synovial joints can be classified according to the shape of their articular surfaces and the movements they primarily allow. The six major types are plane joints, hinge joint, pivot joints, condyloid joints, saddle joint, and ball and socket joints. Let's go through each one. Plane joints have relatively flat or slightly curved articular surfaces. Their primary movement is gliding. A common example is the intercarpal joints of the wrist. The movement is relatively small at each individual joint, but together these small movements contribute to the overall mobility of the wrist and hand. Hinge joints primarily allow flexion and extension. Elbow is the classic example. The interphalangeal joints of fingers and toes are also an example. The knee is often described as a modified hinge joint because its mechanics are more complex than a simple hinge. Although flexion and extension are its major movements, the knee also involves small amounts of rotation and translation. Pivot joints primarily allow rotation around a longitudinal axis. A good example is the proximal radioulnar joint. At this joint, the radius rotates relative to ulna during movements such as pronation and supination. Another important example is the atlantoaxial joint between the first and the second cervical vertebrae, which contributes significantly to the rotation of the head. Condyloid joints are also called ellipsoid joints, generally allow movement in two primary planes. These include flexion and extension, as well as abduction and adduction. A combination of these movements can produce circumduction. The radiocarpal joint of the wrist is a common example of condyloid joint. A saddle joint has articular surfaces that are concave in one direction and convex in another. The classic example is the first carpometacarpal joint of the thumb. This unique shape allows a wide range of thumb movements. It is particularly important for opposition, which allows the thumb to move across the palm and interact with the fingers. Ball and socket joints are multi-axial synovial joints. The major example are the shoulder and hip. They allow flexion, extension, abduction, adduction, and rotation. They can also perform circumduction, which is a combination of several movements. Although both the shoulder and hip are ball and socket joints, their mechanical characteristics are quite different. The shoulder prioritizes mobility while the hip generally provides greater stability because of the deeper socket and surrounding structures. Now we come to one of the most important sections of this lecture, joint mechanics. To understand normal joint movement and manual therapy, we need to understand what happens not only to the bones but also between the articular surfaces. This brings us to two important concepts, osteokinematics and arthrokinematics. Osteokinematics describes the movement of bones relative to the body and around a joint axis. Examples include flexion, extension, abduction, adduction, and rotation. When we say that the elbow is flexing or the shoulder is abducting, we are describing osteokinematic movement. In simple terms, osteokinematics describes the movement that we can observe externally. But this is only one part of the story. Inside the joint, the articulating surfaces are also moving relative to each other. That brings us to arthrokinematics. Arthrokinematics describes the movement that occurs between the articular surfaces of the joint. The three basic arthrokinematic movements are roll, glide, and spin. These movements often occur together during a normal joint movement. Understanding these three movements is essential for understanding joint mechanics. First, let's look at roll. During rolling, new points on one joint surface come in contact with new points on opposing joint surfaces. A simple way to visualize this is to imagine a wheel rolling along a road. As the wheel moves, the contact point continuously changes. In a joint, rolling can contribute to movement, but pure rolling would not normally be sufficient for most joint movements. If a joint surface simply rolled without accompanying glide, the joint surface could eventually move off the opposing surface. Therefore, roll is often combined with glide. A glide or translation occurs when one point on one joint surface contacts multiple points on the opposing surface. In simple terms, the joint surface slides relative to the other surface. Gliding is particularly important because it allows the joint surfaces to remain appropriately aligned during movement. The third arthrokinematic movement is spin. Spin occurs when a bone rotates around a relatively stationary point of contact. A simple example is a spinning object rotating around its center. In real joints, roll, glide, and spin may occur individually or in combination depending on the joint and the movement being performed. Normal joint movement often requires a combination of roll and glide. Imagine a convex surface moving on concave surface. If the convex surface only rolled, it would move towards the edge of the concave surface. The accompanying glide helps maintain appropriate contact between the joint surfaces. This relationship is described by the concave convex rule. This is one of the most important principles in arthrokinematics. When a convex surface moves on a stationary concave surface, the roll and glide occur in opposite directions. For example, if the convex surface rolls upward, the glide will occur downward. In contrast, when a concave surface moves on a stationary convex surface, the roll and glide occur in the same direction. So the basic rule is convex moving on concave, roll and glide are opposite. Concave moving on convex, roll and glide are in the same direction. This principle is especially useful when analyzing joint movement and manual therapy techniques. However, remember that real human joints can have more complex mechanics. So, the convex concave rule is a useful framework rather than a complete description of every joint movement. Another important concept is the closed pack position. This is the position in which the joint surfaces are maximally congruent and the surrounding capsulo-ligamentous structure are generally under high tension. The joint is therefore very stable. Because the joint surfaces and surrounding tissues are tightly engaged, there is relatively little available joint play. The opposite concept is the loose pack position. In this position, the joint surfaces are less tightly compressed and the capsule and ligaments are relatively relaxed. This generally allows greater accessory movement or joint play. Loose packed positions are therefore particularly important when assessing or applying certain manual therapy techniques. Joint play refers to small accessory movements that cannot normally be performed voluntarily. These movements may include small gliding, translation, and distraction movements. Although a patient cannot normally perform these movements actively, they are essential for normal joint mechanics. A joint needs sufficient accessory movement to allow the larger physiological movements to occur smoothly. Physiological and accessory movements. It is important to distinguish between them. Physiological movements are movements that a person can normally perform voluntarily, such as flexion, extension. Accessory movements occur between the joint surfaces. These include roll, glide, spin, and small distraction movements. Normal movement depends on the appropriate interaction between these two systems. Why does all of this matter in physiotherapy? Because movement restrictions can have different causes. A limitation may be influenced by pain, muscle length, capsular restriction, ligamentous restriction, joint surface mechanics, swelling, or other factors. Understanding arthrokinematics helps us analyze movement more accurately. Instead of simply asking, why can't this joint move further, we can ask, what structure is limiting the movement? Is it muscular or capsular? Is it the accessory movement or the pain which is limiting the movement? And what intervention is appropriate? The type of reasoning is important in physiotherapy assessment and treatment. Manual therapy includes techniques designed to influence pain, mobility, and joint function. Examples include joint mobilization, manipulation, and distraction. The choice of technique should always be based on appropriate assessment, clinical reasoning, patient presentation, and the therapist's training and scope of practice. Joint mobilization involves controlled passive movements of a joint or its accessory structures. Depending on the joint and clinical goal, a therapist may use technique such as gliding or distraction. The direction, amplitude, duration, and intensity of a technique can vary. Understanding the joint surfaces and the convex concave relationship can help the therapist understand the direction in which an accessory glide may occur. However, clinical decision making should not rely on the convex concave rule alone. Manipulation is a manual therapy technique involving a controlled high velocity, low amplitude movement. Because manipulation requires appropriate assessment, screening, clinical reasoning, and technical skill, it should only be performed by appropriately trained healthcare professionals within their scope of practice. Now, let's discuss joint stability. Joint stability refers to the ability of a joint to maintain appropriate alignment and control during movement and loading. Stability is not provided by one structure, it is the result of several factors working together. These include joint geometry, the capsule, ligaments, muscles, tendons, and neuromuscular control. We can broadly divide these contributors into static and dynamic stabilizers. Static stabilizers provide passive resistance to unwanted movement. These include the shape and congruency of joint surfaces. The joint capsule, ligaments, labra, and menisci were present. These structures are particularly important for maintaining joint stability when external forces are applied. Dynamic stabilizers are primarily the muscles and their tendons. Unlike passive structures, muscles can actively adjust their force during movement. They help control joint position, respond to external loads, and maintain alignment. This is why muscular strength and neuromuscular control are important. Components of functional joint stability. A capsular pattern refers to a characteristic proportional limitation of joint movement associated with the involvement of joint capsule. The important point is that the restriction is not necessarily equal in every direction. Different joints have different characteristic patterns. Recognizing a capsular pattern can provide useful clinical information and may suggest that the restriction is related to the joint or its capsule. However, a capsular pattern is a clinical finding and should not be considered a diagnosis by itself. Another useful clinical concept is the end field. End field describes the quality of resistance perceived at the end of passive joint movement. There are several types of end field. A soft end field occurs when the soft tissues approximate at the end of the movement. A firm end field can occur because of tension in muscles, capsules, ligaments, or other soft tissues. A hard end field is typically associated with bone to bone contact. The expected end field depends on the specific joint movement. Therefore, the therapist needs to know what is normal before deciding whether an end field is abnormal. Accessory movement is movement between joint surfaces that accompanies normal physiological movement. Roll, glide, spin, and distraction are important examples. These movements may be small and difficult to observe externally, but they are essential to normal joint function. When accessory movement is significantly restricted, physiological movement may also become restricted. This is one reason arthrokinematics is so important in physiotherapy. Let's quickly review the key points.
Welcome to the study of arthrology. Joints are classified as fibrous, cartilaginous, or synovial. Synovial joints feature cartilage, a capsule, and a membrane.
Arthrology is not simply about memorizing names and classification. The real goal is to understand the relationship between structure, movement, mechanics, and stability.